Okay, well, I want to say, first of all, good evening to everyone. It is terrific to be here with you. It's actually a really nice day in Nova Scotia. I hope you've enjoyed it. And I certainly also am really privileged to be able to be back at COVID-19 Town Hall after many, many, many months. Just to give folks a little bit of background, even before the province declared a state of emergency, leaders in the Black and African Nova Scotian communities understood that protecting and educating our communities about the virus would also involve working against systemic racism and inequities within the health system. In March of 2020, the Health Association of African Canadians, HAAC, held a town hall to address online misinformation, because there was misinformation directed to us about us, and we wanted to correct that, particularly because the misinformation was suggesting to our people that we couldn't get COVID or that we were not likely to get COVID, when in fact the exact opposite was true. And so we had the town hall to alert communities about the disproportionate impact it was likely to have on our people. And at that point, the government of Nova Scotia had not declared a state of emergency, but we were concerned. So that first town hall happened then, and at the same time, the Association of Black Social Workers, also known as ABSW, and the Health Association of African Canadians, also known as HAAC. I won't say the full names again because it will exhaust all of us. But we together took action as well. And the Association of Black Social Workers established a province-wide toll-free number that responded to questions, provided support and services, and made referrals based on the needs of individuals and organizations in the communities. My co-manager of the COVID-19 African Nova Scotian initiative, COVID initiative, Veronica Marsman, who may be able to join us, but she is so working hard these days, and she's actually out of province and at a meeting, if you could believe it. But when we were starting out with this work, the initiative was certainly formed to create awareness to combat the pandemic within Black communities and African Nova Scotian communities, with collaboration and partnership in the forefront. And we were known then as the Impact Team. We are now the COVID Initiative. We've gone through the pandemic and all of the various roundabouts and circles, but we've kept our integrity in terms of cultural specificity and in serving our people in ways that are culturally competent and in ways that will inform, protect, and keep safe. So tonight, this is another of our town halls, albeit quite far away from those initial ones. And it is tonight a town hall that we are presenting in partnership between ABSW and HAAC, and also Nova Scotia Health, and particularly public health. We are delighted and always grateful that we have our admin coordinator and admin assistant helping to host this. Carla, we call her the Carla Glue because she keeps it all together for us. She is actually on vacation. We have just delivered the first ever in the history of this country International Black Health Conference, in which we talked about our initiative. And so Carla's having a well-deserved break, but we are not in any way caught flat-footed because we have Kate with us. And Kate McKaysey is an administrative assistant who we are so pleased to have working part-time to support us. Kate is here, and I'd love to see your beautiful face, Kate. There she is. And so thank you to you and to Carla for hosting. And tonight we are going to be hearing from some leading physicians in this area who will talk to us about the state of things and opportunities for people of African ancestry, regardless of where they were born, African Nova Scotians and Black people who live in this province, that they will have an opportunity to hear from the experts about the pandemic, the changes. We're going to hear from Dr. David Haase, Dr. Ryan Sommers, Dr. Lisa Barrett, and Sister Rose Fraser, who are going to cover the topics of variants and repeat infections, I should say, vaccine updates, drug therapy updates, and vaccine clinic availability in that order. I also would love to welcome back to our HAAC Town Hall screen, Dr. Gaynor Watson-Creed. We started out with Dr. Gaynor. She was our person, because at that time, in a former life, she was the Deputy Medical Officer of Health, and she always came to our town halls providing culturally specific information and informing us in a way that was accessible and well appreciated. Many a town hall, she was at the forefront. You're still at the forefront with us, Dr. Gaynor, so we're happy to see you here with us tonight. So first of all, I would like to ask the participants, and I know there will be more. This is, of course, the supper hour, and my co-president, Sister Rhonda Atwell, always agrees with me that it's also the witching hour, because you got to get kids fed, bathed, homework done, and try to get on screen as well. So we know we're very understanding that people may be joining us a bit later. But as it is now, I am going to ask that participants write their questions down, as opposed to, every few minutes stopping for a question, because we think that will help the flow. And there may well be things that are said through the presentations that are going to answer your questions. So what we would really appreciate is, you could certainly put comments in the chat. People are already doing that. But that at the end of the presentations, we're going to have a fat 40 minutes, maybe even an hour, to have questions answered, to hear comments, points of view, and so on. So don't worry, but please do write your thoughts down so you don't lose them. And having said all of that, now I would like to ask our colleague and beloved HAAC past president, Dr. David Haase, to introduce himself.
Thank you, Sharon. So I'm Dr. David Haase, retired infectious diseases and internal medicine physician, member of HAAC and the co-president of the Black Physicians of Nova Scotia group. And then we put a trivia question to you. You don't need to answer right away. Just think about it. How many significant tropical and subtropical storms have we had in the Atlantic this season? So think about that. Don't look it up. Just think about it. And then we'll come. It's relevant. We'll come back to it. So we're talking about a virus tonight. And I don't know if you recognize that viruses are the most common life form in the world. Now, you may say, it's not alive. Viruses are not alive. Well, depends on your perspective. They have structure, function, and they have a purpose as well. And so we're going to kind of talk about that. The first main purpose that viruses have is to keep making copies of themselves. And so they do that ad nauseum. That is one of their main purposes. Copy, 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 duplicate, duplicate. The second main purpose is because viruses cannot do this on their own, they need to be within host cells. So their second main purpose is to get into as many hosts as they can and get into as many cells as they can so that they can make as many copies as they can. So they have structure and function and a purpose. They're also globetrotters. Viruses, you hear of a virus, a particular virus at one end of the globe, and in a few days, a couple of weeks maybe, it's in many countries. So they're globetrotters. And it's interesting that they travel light. Their travel kit is very light. So they're made up really of a genetic code or blueprint, if you like, and that's contained in a bag in an envelope, a lipid envelope or a greased envelope, as some people like to describe it. And so that's a very simplistic, structure, but it works. And all the virus structure, everything in that virus structure works towards the purpose of copying itself and, infecting other hosts as they go along. It's interesting that this viral envelope also has embedded proteins in it. And the most notorious of these proteins, of course, is a spike protein, which looks like a club. It has a long stalk and a kind of a bulbous head, if you will. And when you cut the virus cross-section, you get this corona-like appearance, like a crown. That's how it got its name. But all of these structures have function, and the spike protein, which you keep hearing about, and Dr. Sommers is going to talk about, I'm sure, is really instrumental in attaching this virus to the cells that it needs to get into. All these structures also help to protect the virus, and some of them help the virus evade the immune system as well, which is something that we'll talk about as we go along. So the spike protein is really the main sort of instrument that the virus uses to hang on to cells. There are certain receptors on the cells, not easy to get into cells, but these spike proteins, and again, we're not going to go through details of how it happens. It's like when you put a key in your front door and you open the lock, that's how it kind of works. And then the genetic blueprint gets into the cells and then hijacks the cells. So each of our cells has a manufacturing, a factory, if you will, and the virus takes over that manufacturing plant. It does a number of things. It suppresses the cellular manufacture of its own products. It also suppresses the cellular defense, and there is some defense in cells. And then it takes over and it hides itself in a place where, it kind of is tucked away, and it makes copies. So it copies the genetic blueprint, and it copies and makes components that it will use to make other virus particles. These are made and they're packaged, or they're assembled, and then they're packaged in an envelope and they exit the cell. They go on to infect other cells. And in some cases, there have been shown that these viruses can transmit or pass from cell to cell directly as well. So, they hide themselves from the immune system that way. So they go on, and that's really what they do. And hundreds or sometimes thousands of these viral particles are exited from the cell. So how do we get these variants? What happens is when you look at the genetic blueprint, there are about 30,000 individual little blocks in this blueprint, and I'm simplifying this. But as it's making copies, and this happens really with all living things, but viruses in particular, and this particular virus is more prone to mistakes. So if you think about it, as it's making copies of this blueprint to package in other viral proteins, mistakes are made and you get the wrong building blocks put in. Now, these building blocks may have a negative effect because, those blocks are going to be used to make other viruses. And so the structure of the new viruses may change depending on how significant the change is in these genetic sort of building blocks, this genetic code. If it's a negative change, that is, the virus, the new virus, for instance, may not be able to grab onto cells as well, may not be able to evade the immune system as well, then that particular variant or mutation is not going to survive and will disappear into thin air like magic. If it's a positive effect, that gives that virus some survival advantage. Because remember now, it's a survival thing, right? And only the strong survive, if you will, or survival of the fittest. So if it gives an advantage in how it grabs onto cells, how it transmits from host to host, more transmissible, if it's able to evade the immune system more readily, then that particular variant, that the mutation is going to survive and in fact may take over as a predominant variant in the sort of infectious sort of arena with these viruses. So that is the key thing, that you're going to have variants, there are multiple mutations, but only the ones that give an advantage for survival are going to really become significant. And even in fact, if you think about it, the virus, the symptoms that people have are really related to the immune system response to the virus. And that immune system response can be powerful enough to kill the host. But think about it, if you have a virus in a host, like a human host, and that person dies, that virus is not going to survive. So there's no survival advantage in killing the host. And ultimately, the key for these viruses, and there are other examples, is really to cause infection without the host dying. And that's the key thing. So when we think about these variants, that's a key to understanding really the whole issue of infections and reinfections. Because you have immunity which is conferred, which is produced or induced by natural infection, and immunity from the vaccines. And the key about these variants is that, particularly the more recent variants, is that they're better at evading that immune response. And so because they're better at evading that immune response, they can then cause more infections, reinfections, escape vaccine induced immunity. And of course, there is waning of immunity as well. And I'm going to leave that to Dr. Sommers to talk about. So let's get back to this trivia question about tropical storms. Does anyone here know what number we're up to right now? Just shout it out. And do you know how and why they name these storms? Nobody. All right. So tropical and subtropical storms, storm systems, are named when they become significant. They have a significant wind speed and are sustained at that level. Then they get a name. And the names are taken from the English alphabet, 26 letters of the English alphabet, and they have a name for each letter. We're actually up to number 11 right now. And if you think about it, Fiona that hit us was number 6. And Ian that hit the US so hard was number 9. So now we're up to number 11. And what I want to illustrate to you is that there have been others that have been named because of their significant strength that haven't had an impact. So we haven't really known anything about them. It's the same thing with these variants. So these variants are named using the Greek alphabet. So there was an original initial virus. We can call it ancestral virus. And then you had mutations coming along producing variants. And so these variants, now they're using the Greek alphabet. This is 24 letters. And if you think about it, Delta, which was one of the most dangerous variants, was number 4. Omicron, which is the one that is here now, is what number is Omicron? It's number 15. So think about that. That means there have been others in between that we've not heard much about. So they haven't really had that much of an impact. But Omicron now in Canada, for instance, 90% of our isolates are Omicron. And so Omicron is now taken over. It's more transmissible than the Delta. It's more evasive in terms of the immune system. And it's very interesting that it causes less severe disease. It seems to be causing less severe disease. Now, Omicron has subvariants and they're labeled, it's very confusing. They're now labeled BA1, BA2, BA3, BA4, BA5, and we're up to BA5. And again, as these variants and subvariants come into play, they're being watched very carefully to see if there is something else in their characteristic that's going to make a big difference in terms of, because the most things that we're worried about, of course, severe disease and death. And so, and again, I'm going to leave it to Dr. Sommers to talk about the vaccines, but the whole issue there is, vaccine protection with all these variants coming along. And so the key then for us is, just to remember a couple of crucial things before I finish. So the variants really are related to the mistakes that the virus makes when it copies that genetic code, that string of that genetic code that it needs to pass on from virus to virus. So it's a random thing, but survival of the fittest, whichever variants give a survival advantage to that particular mutation, those are the ones that are going to survive and take over. And of course, one of the things is evasion of the immune system. The other thing then to remember is that the reinfection and breakthrough infections that we keep hearing about are directly related to this whole issue of the variants and the fact that as we get more and more variants, and we will get more because that's just a fact of life with these viruses, as we get more and more of these variants, we will get variants that, because they evade the immune system so well, the immune response, they will be the ones that survive more and more and more. And so I'm going to stop there, and we'll be happy to take questions when the time comes. Thank you so much.
Thank you so much, Dr. Haase. In fact, Dr. Gaynor was saying that she wants to have a board game developed with you in charge, talking about fun with infectious diseases, which is wonderful. But we certainly learned a lot, and I'm thinking of some questions too because of what you ended with there. But let's go on and make sure we get we hear from all of our presenters first. So I'm very, very pleased to ask Dr. Ryan Sommers to introduce himself and then to talk to us about the vaccines themselves.
Great, thank you. Can you guys hear me okay?
We can hear you, yeah.
And can you see my screen now too?
Yes.
Okay.
It looks like it's in presenter view, just if that, I'm not sure if that's what you're going for there.
No, it's not.
I think if you click use slideshow,
Just use slideshow, yeah.
Yeah.
Use slideshow.
There we go.
Yeah, there
we go. Excellent. So yeah, my name's Ryan Sommers. I'm initially trained as a family doc and then got enticed to go back and do more training. I'm a public health physician who works with Nova Scotia Health. This is the second time I've had a chance to participate in a town hall meeting, so thank you for inviting me. A little disclaimers first. I don't have any financial interests. I have no conflict of interest. I don't do any research or get any funding from any industries at all. I just get paid to do my job. One thing I always tell people, it's amazing how much we have learned around this virus and vaccines over the past 2.5 years now, and our breadth of knowledge continues to expand. So I always remind people, like, the things I talk about today, probably in a week they could be outdated. So it's so everything I'm talking about today is everything we know from the scientific literature and from what we've seen in practice as of today. So I guess the first thing I should do is obviously thank you guys for involving me in the town hall. I want to thank the participants for taking time out of their evening to listen to what we're talking about. But I also want to thank ABSW and HAAC for all the work that your organization has done over the past 2.5 years. One of the best things I love about my job of being a public health doctor is working with the community, working with community groups. And over the past several months now, I've had a chance to interact with David, Veronica, and Sharon, and it's been really rewarding. It's making my job easier in a sense, but also keep me very busy as well, which I don't mind that at all. I think your organizations are really fortunate to have you guys leading and providing advocacy and education for Black Nova Scotians as we go through the pandemic. So thanks for involving me, and thank you for all your help that we've been working on. So this is a picture of a new roller coaster they're going to make in Colorado. It's actually going to be built on a mountain. And I like using this analogy to explain the ride that we have been on over the past 2.5 years. It's definitely been up and down. Wave one was, it felt like they're turning to go, but also lasted forever. And I remember that's probably the most hardest I've ever worked as a physician, whether clinically or as a public health doc. But we've been on this up and down journey where we had this brand new virus show up, didn't know anything about it, trying our best to contain and protect the population. We then amazingly, within a year, we created vaccines, which is just blows my mind how science technology has come this far. And then the virus kept getting ahead of us, and we were able to adapt the vaccine. But it's definitely been one heck of a ride, and there's been a lot of ups and downs. And I'm not sure where we're at on the roller coaster. I'd like to turn it off and get off it. I'm not sure what's exactly going to happen, but we're coming down, and there's hopefully less peaks and valleys and a little more stability of what we're going into. But I think one thing I really want to get across to the audience tonight is, vaccines are making a difference. And we have known that for hundreds of years now that vaccines have actually saved lives. You actually calculate a vaccine, like every second, about 4 to 6 people are saved because of the amazing technology vaccines have provided us. This is for all vaccines. And we're starting to see COVID vaccines make a difference as well. Initially, when the first vaccines were produced, our goal was we want a vaccine that's going to help keep people out of hospital, prevent them from getting the ICU, and prevent them from dying. And we had a threshold of, let's decrease that by 50%. And so when the vaccines first came out, they actually exceeded our expectations. They're very good at preventing the transmission of the virus, preventing the actual symptoms from developing, and also keeping people out of hospitals. But this virus is tricky, and as David alluded, that it is something that changes quite a bit. It's been able to change its appearance, change its structure. Those little spikes that come off it, those are I think Dr. Barrett used it before in the presentation. Those are what makes it so sticky. And this virus has been mutating much faster than other viruses we know about, like the flu virus is about 4 times faster. So it's keeping us on our toes, and we're having to continuously reassess our vaccines, and the vaccine producers now are actually modifying vaccines to be more tailored to the specific strain or variant that we're seeing. One of the big differences, and this is a busy slide, I apologize, is the vaccine is working at keeping people out of hospital. This is a slide that you can get off the Department of Health website, and it details everything from March to this past month, and it details the number of hospitalizations and admissions to hospital that we've seen. And if we go back in time to spring of 2001, we had that Easter wave, the third wave, and that put a considerable amount of pressure on our healthcare system. We had at one point over 200 people in hospital being actively treated for COVID. Because of the great work that our communities have been able to do to get the vaccine in arms, and also having therapeutics, that those numbers of people in the hospital have gone down quite a bit. We still have people ending up in the ICU. We still have people in hospital who are needing active treatment to manage the infection. But we also are seeing a lot of people who happen to have COVID are in hospital for some other reason, but they're not needing that treatment. And so they're during the crazy roller coaster ride that happened in the spring, we've had some pretty consistency now in terms of the number of people in the ICU. And so that's the bottom number there, that little green line with the darker blue bars. And then the green line above that with the lighter colored bars represent the hospitalization. So the vaccines have worked to keep people out of hospital. For those people who do end up in hospital, it's actually working to keep them out of the ICU. And also, people get vaccinated, they're having lower chances of dying. This slide's a little bit updated, but it came from the federal government, and it sort of details what's happened to vaccinated individuals and unvaccinated individuals. And so this is like a hospitalization. And this actually has the fifth wave, the Christmas wave. And you can see that the people who were unvaccinated made a bigger portion of people in the hospital compared to those who are fully vaccinated or vaccinated with a booster. And so recall that back in January, there's this big effort to get that booster shot in arms. We knew that booster, on top of having the original 2-dose vaccines, it made a big difference in protecting our healthcare system. So vaccines work, they protect the individual, they protect families, they protect the community, and more importantly, there's a lot of pressures on our health system right now, and they're protecting our health system. It's particularly important for Black communities to get vaccinated for a number of reasons. So we know from studies in Canada and the United States that due to anti-Black racism, social and economic factors, people of African descent are at higher risk and higher rates for contracting COVID-19, and they're disproportionately affected by severe illness and hospitalizations. There's been a lot of studies of this in the States. They do a very good job at collecting information on Black and African American populations, and what they saw was those communities, those Black communities, had a higher rates of infection, higher rates of hospitalization, and higher rates of death. And part of this is that we know that Black populations have higher rates of chronic disease. So things like heart disease, lung disease, kidney issues, certain medications you can take can make you more prone to getting COVID. And what we've learned as well is that getting vaccinated with your 2 doses plus a booster, it is going to protect communities. It's also particularly going to protect our communities of African descent over a long period of time. The one thing that we're coming to realize now is that COVID is going to be with us for the short term and for the long term. Time will tell to see what's going to happen with future waves. I'm hoping that we'll not see big peaks like we have seen in the spring, but we still have to adapt to this virus. And one of the things we're trying to do is having and promoting a fall immunization campaign around COVID. A lot of experts believe that depending on what happens this fall and winter, and looking at what potential new variants will emerge, we could be looking at a vaccine campaign like we see for flu. Like every fall, you get your flu shot and you'll get your COVID shot. But that's the ideal direction we'd like to go. But only time will tell, and we'll see what happens. Another big thing that we're learning about the vaccines is if someone has been infected and vaccinated, it actually provides even stronger immunity, and we're calling this hybrid immunity. So there's various portions of your immune system that can fend off infections. Vaccines are good at strengthening one portion of it. If you actually get infection, that strengthens other portions of it. But studies have shown that if people have been infected and they've had the vaccine, it actually has a protective effect. As David mentioned, there is some waning immunity with the vaccine. So with time, we're seeing anywhere from 4 to 6 months, you'll have that immune protection, but it does diminish over time. And this is a lot like what happens with the flu shot. We tried the flu shot in the fall, so you get ready for the late fall, winter flu campaign, and you get about 6 months. That's the time of year we see most of the virus circulating. So boosters are really important because they're going to get all that protection, but it's also important if you've been infected, because it's actually an additional way to protect yourself from any future infections. So there are efforts now to do to have a fall vaccination campaign. I'll admit it's been very confusing with all the vaccine products that we have out there now. This is probably one of the first time in history the entire society has watched a vaccine be made. Usually vaccines take from 5 to 10 years to be made. Amazingly, we were able to produce a very effective vaccine in a short period of time, and people are following this along. They're keeping an eye on the news. They know which brands are out there. So it's we have a very attentive population, and trying to explain what is the best thing you can do for yourself and your family and communities is going to be very challenging in this fall, because it all depends on a number of factors. It depends on your age, if you're from a particular population, and your health issues, and what other vaccines you've had at this point. So I'm going to try to make this as easy as possible so people can understand what is required for a fall vaccination campaign. I'll first talk about the bivalents. So a lot like the flu vaccine, we're creating vaccines now that have 2 different strains in it. So the new bivalents will have the original strain, which is based on the first vaccine that we made against coronavirus. And it's now having the new Omicron variant. So the Omicron variant is the most common variant we're seeing now. As David suggested, that there's various types, BA1, BA2, BA4, BA5, the list goes on. So now, just like we do for the flu shot every year, we're trying to tailor the vaccines to the specific type of virus that could be circulating in our communities. And so there's a little picture there that, these are called mRNA vaccines. mRNA is like the genetic instructions for that little spike protein. And it's actually technology we've had around for a while now, but instead of having just one of these mRNA components, we have 2 now. So it's going to hopefully provide an additional stimulus to our immune system, and so it gets turned on. It's going to identify these Omicron variants. So as of today, October 13th, 2022, we only have one bivalent available. It's the Moderna bivalent. It has the original virus strain plus a BA1. Some of you may have heard the news last week that Pfizer has produced a BA5 bivalent, and it has been approved in Canada, and it will be probably within the next few days. We'll know when it'll be available for booking in Nova Scotia. The standard practice is that we wait till we actually have supply on hand in the province, and when we have that, using the Immunization website, people can go in and start booking their vaccines. So that should hopefully be released very soon. People behind the scenes for Immunization are preparing the website, getting the consent forms done. So please stay tuned. But this will be coming. I'm suspecting in the next possible week or 2 that these bookings the website will open up for booking. So stay tuned to the media for that one. So the bivalent vaccines, the advantage they have over the first vaccines is that they make more antibodies, these little flags that help identify viruses in our body. They have the same type of very mild side effects that we are seeing with the initial vaccines we had. We know that it does give strong protection from severe illness. It does lower the risk of COVID-19 symptoms. They're not as severe, and it also lowers the risk of complications. The big complications are hospitalization, and the ICU, decreasing death. And there's also another complication is long COVID, people who have these prolonged symptoms. So I'm going to do this bullet point by bullet point to show you what the recommendation is going to be going forward. So if you had not had any vaccine at all, we're recommending that people get the original strain vaccine. So this is the Moderna Pfizer products. The bivalents have only been approved in Canada as booster doses. They have yet to be approved as something you can do as your primary series or your first 2 shots. If someone has only had one vaccine, it's the same recommendation. You should get the original Moderna or Pfizer vaccine. For those who've had the primary series and they're between the ages of 5 and 11, they are now approved to get boosters, but it is the original strain. At some point, maybe later this year, we're expecting Pfizer and Moderna to submit to Health Canada a request to use the bivalents in the 5 to 11-year-olds, but I don't think that's going to happen for at least a couple more weeks. It has recently been approved in the United States, but those companies have not submitted them to Health Canada yet. If you had a primary series and no booster, and as of today, we're saying 18 and above, we're recommending a bivalent. So it will be Moderna or it will be Pfizer. Pfizer has been approved for 12 and above. That's why I wrote 18. That's what we know is today. But 12 and above, and you had no boosters yet, we're going to say get a bivalent. Interesting, the Moderna bivalent is approved for 18 and above. The Pfizer bivalent is for 12 and above. And finally, if you've had a primary series and you've had a booster, and it's been a certain time frame since that last booster, we're encouraging you to get a bivalent vaccine. So many people are at a point now they could get a fourth dose or their second booster dose, and we're recommending bivalent as well. Just a couple little comments here on timing. If you're getting the original series, you want at least 56 days between your first dose and second dose. If someone's immunocompromised, we short that down to 28 days. And then boosters, if you're getting a booster, we want that to be at least 6 months from your last booster or infection. So we're sort of treating infection in a sense, it's like you got a vaccine, and it does stimulate your immune system. For specific populations, that can go down to 120 days. And so I'll show that on the next slide what those populations are. So 120 days is about 4 months. So for those in this group, these individuals, it's 120 days between their last dose or their last infection. So adults over the age of 70, those over 18 who are living in long-term care settings or senior congregate settings, pregnant persons, adults in or from First Nation communities at 55 years and older. And then this is the one I obviously want to highlight for this audience is, after disclosure, adults age 50 and above or older, you can get your booster dose. And again, that can be 4 months from your last infection or your last dose. So that's probably the key highlight message I want to get across there. And then the other thing is individuals 18 and older who are moderately or severely immunocompromised, that can be due to a medical condition or to medications they're taking. The last thing I'll say, I'm just a little plug on this one too, that probably this week, depending where people get their annual flu shot from, is don't forget about your flu shot as well. So the flu actually results in about 12,000 hospitalizations every year before the pandemic. It results in about 3,500 deaths per year in Canada. So it's a significant impact on our population as well. And getting the vaccine is a lot like the COVID vaccine. It can prevent you from getting severe complications. Now, we've had it pretty good the past 2 years because of COVID. We have had all these masking policies and distancing policies and gathering limitations. So we've helped prevent the spread of COVID, but we also help prevent the spread of the flu vaccine. And it's going to be particularly important for kids under the age of 6 months to 5 years old, and also those over 65 to really get their flu shots, because we're expecting to see a lot more activity. We always can look down to the southern hemisphere. They have their winter during the summer, and we can see how bad their flu season is. And we know in Australia that they opened up their public health their societies. There were fewer public health measures, and they saw earlier flu season, and they saw a lot more kids. The majority of the kids were under the age of 10. Fortunately, it didn't have a very significant impact on their healthcare systems, but it's something that we're going to expect. Well, we've already started seeing some lab tests come back positive for flu, but I can't stress this enough. And with the exception of vaccine for kids under the age of 5, people can get their COVID shot and their flu shot at the same time. So if people are going to their pharmacy, they get a COVID shot, they can get that at the exact same time. There's no need to wait a couple weeks before or after. I'll leave it at that. I think I used up most of my time, and I will stop sharing my screen, and I'll wait for the formal question period.
Meeting. Okay, there we go. Thank you so much, Dr. Ryan. That was really, really clear, and I appreciated the slides to show us, you know, when you can get it, how you can get it. That is the best opportunity I've had to understand that so clearly. So thank you very much for that. And no doubt we'll have some questions going forward. And I think then moving right along so that we can hear all the presentations in their entirety, we should introduce Dr. Lisa, or at least ask Dr. Lisa to introduce herself, and then take it away and tell us about those, what will I call them, therapies? Maybe not? Help me out. Okay. Over to you, Dr. Lisa.
I love the therapy part. So I'm Lisa Barrett. I'm one of the infectious disease doctors, and I've been doing a lot of COVID work for the last couple of years. With me this evening is the person who co-leads therapeutics for the province, Dr. Tasha Ramsey. She is a clinical pharmacist and expert in lots of things, but that includes COVID as well. And she's been helping to co-lead this effort across the province. So she can jump in as well as we're going along. And Lisa Nodwell, who's her partner in crime on the pharmacy side. And why? Why are there 3 of us? Well, this has really and truly been an exceptional opportunity to collaborate between clinicians in the medical field as physicians and our pharmacists. And in fact, without one or the other, this would not have been such a success. So we're all here together tonight. I do recognize we're a little behind time. So what I'm going to do is give some really super high level kind of concepts. And then I'd love to hear what the real questions are, because I think I know what some of them are, but I never guess right. So we'll do some high-level concepts. First step, I think, before we get into the meat of the matter, if you will, it is dinner time, is just, I think it's reasonable to take a moment and acknowledge the impact and all the feelings around COVID in general. I've got a lot of them. Most of us have had people in our families and extended families that have either had COVID, gotten great care and felt better, or gotten COVID and had a vaccine, had a rough go, but recovered. But most of us know some people that did not recover and aren't with us anymore. And I think it's okay for us to acknowledge that as we go forward. And yeah, just pause for a second, because I think it's impacted all of us. And then the second piece, before I get into those medication or drug therapies, is the fact that it's still okay if you're in one of those camps or groups that really doesn't want to run into COVID and you're doing everything not to get it. That's okay too. Vaccines are the key cornerstone of that basic plan, as well as it's okay to continue to do some of the things that Dr. Sommers and his colleagues are recommending around public masking, staying home when you're sick if you can, and the hand washing stuff. We do still have tools in our toolbox, including vaccines, to stay as healthy as we can this fall. So just before we get into this other piece, you run into COVID and you don't outrun it, you get COVID. What do you do then? And that's okay too. Also acknowledging that this is not a shame game. It's okay to get COVID. Most of us probably have had it. So you get COVID, what are the options in terms of how to feel your best? Well, there are lots of things to do that are care, and there's lots of resources between Nova Scotia Health, 811, Public Health, to reach out and get care and support in terms of what you do. But here's the thing that I'm supposed to talk about, and that's what about these medication therapies, these drug therapies? What are they? Who are they for? What are they supposed to do? And are they really safe to take? How do I get them if I need them? So we divide COVID into a couple of different buckets, if you will. The non-severe version of COVID, you're in the community, you're out there, you don't need oxygen, you feel pretty crappy, or you don't feel that unwell at all, but you don't require oxygen and don't require other therapies that require you to go to emergency or to be admitted to hospital. And then there's the other group of individuals who get COVID and then end up needing additional therapy or oxygen, fluids, support. They may develop some delirium, especially in older adults. If they get COVID, that's a common thing that we see. They may develop, if they have underlying other problems with their health, their heart, their kidneys, those problems may get worse if they get COVID. Those folks need to go to hospital. And then in that situation, if they get bad lung symptoms, they may require some medication specifically for COVID. So two different groups of individuals: people without severe disease, not enough infection to require extra oxygen, and then the other folks who do get quite sick and then require hospitalization generally. So there are things that we can do from a medication perspective for people in each of those groups. But guess what? You got to know that you've got COVID. There are lots of respiratory viruses, since we've whipped off our masks, that are floating around in the community, and they can kind of look and feel a lot like COVID. And so if you think that you may have COVID, particularly if you're somebody who has some of the risk factors to get worse COVID disease or more severe disease, you're older, may not have had all of your vaccines, you've got lots of medical problems, and or you're on medications or have conditions that make your immune system weakened, those folks, it's highly recommended that you get a COVID test or do a COVID test yourself. If positive, that's the first thing we need to know. There's a tool that has been developed in Nova Scotia that's really important. It's called the Report and Support Form, and this form is done in conjunction with Public Health and Nova Scotia Health Authority. It's online, and it asks you some questions about yourself and your health. And Dr. Ramsey has just put the link into the chat, which is excellent. This is a really quick, pretty easy form for folks who don't have access to a computer, aren't so great at reading, don't really like answering things on the computer, and computers aren't their thing. There's another number that you can call, and people can help you to fill that out as well. Then that information comes forward, and we get to help understand whether you fall into the bucket where you would need early treatment and non-severe treatment, or if you fall into a different group with moderate to severe disease. And I'm going to pause there because this is really important. This is the prime key way, getting a test, either the self-test you do or a PCR test that can be done at some of the testing centers around the province. That's really, really important, particularly for folks who are at highest risk of developing bad COVID disease. So Phil, if you get symptoms as soon as you can, you don't wait it out. I love Nova Scotians and folks on this call, I'm sure we're all the same. We don't like bothering the health system. We don't want to get in the way. Oh, I'll see if I get better tomorrow. Do the darn test, because especially with some of our early or non-severe therapies, the earlier you get access, the better the result is. So you've got COVID, you did your test, you filled in, or one of your family members helped you fill in, or a friend, or if you don't have internet access or a good friend that you're comfortable sharing information with, you can use the number that's listed in the chat there that Dr. Ramsey included to get your report and support form filled in, just so that people know this is private. It's not shared outside the group of clinicians and so doctors, pharmacists, and nurses that are going to be helping to assess people for whether or not they need to get treated. And then after that, folks are put into a list, and the people who are at highest risk for very bad things, one of our expert pharmacists reach out to folks if you're in the community to help answer more questions, find out how you're doing, and do a really deep dive and understand if you need treatment. After that clinical pharmacist expert assessment, they will decide if you're in the groups of people who may need treatment, generally folks who are older, folks who are under vaccinated or had their last dose of vaccine a long time ago, with other medical problems or a weakened immune system. Those are the folks who we think, with the current medications we have available, and there are several, these are known as antivirals, and there's a couple of names you might recognize from American TV, like Paxlovid, or Remdesivir, or other antibody treatments that either prevent or limit disease. There's going to be some of those coming down the line soon. If you get assessed and you need some of those therapies, our clinical pharmacists, and sometimes if it's one of the more on the edge situations, our physicians as well, will then arrange for you to get that treatment near your home, wherever that is. Most of the time, there's a place to pick up those medications within a short distance, and we can facilitate getting medication to people. Those treatments range between 3 and 5 days, or a one-time injection, depending on which one you're getting. You don't need to know the details about the what. The goal of those therapies is to prevent your COVID symptoms from getting worse and becoming severe. It is not a cure. It is not going to completely make you feel better within a day, but its goal is to prevent people who are at very high risk of going on to get bad disease, of feeling worse. And they are safe medications. We've given them to many, many people in the world, and I can answer questions about the details if people want later. But guess what? We don't get great access to folks unless you fill in the report and support. They are not available on the corner at your random pharmacy. Random physicians can't order them at this point, and that's because of two things. One, there's a somewhat limited supply, and number two, if the right assessment is not done and the right person doesn't get the right medication as early as they can, then there may be some problems. And that's why, for the moment, until we have more information and data, we're doing this in what we would call a designated prescriber mode across the province. So it's not a random drug that you can get at the corner. You have to have a prescription, and you do have to be in the system through report and support, primarily for us to get access to folks. And that's why it's so important to get tested and to fill in report and support. For people in the hospital, there are other medications that are available. Many of those started out as research medications when we started using them in Nova Scotia, and now there are multiple medications. Again, those are not a cure. They are meant to limit the amount of damage to the lungs that happens with COVID if you've got moderately severe or severe disease. For example, if you need oxygen, your lungs are really full of congestion and COVID, and or you may get so sick that you need to go to ICU. Fortunately, with vaccines, that's become a much rarer thing, but we do have medications available all across the province to treat people if needed. If you're in hospital and you still have early disease, you're there because of your broken leg and not your COVID symptoms, you just have a sniffle, we can also get access to you there. And we have ways of filling in report and support with you, or your family can fill it in even if you're in hospital. So lots of different treatments available in the community and in the hospital for COVID. Not a cure, but it does help to limit the amount of disease. And these medications are not for everyone. They don't benefit everyone. And we only give them to the people at the highest risk for very bad things, because that's where we know that they have benefit, not for somebody who's 20 and super healthy and fully vaccinated. Those are not the folks that we're primarily seeking out when we're doing therapy. So I'm going to pause there. I'm going to give Dr. Ramsey and Ms. Nodwell a chance to comment as well. And then I want to kind of zip it up a little bit quickly so that we can give some other folks some time and hear those great questions.
I just had one additional thought there, Dr. Barrett. So there is one exception to the rule when it comes to folks that have what we call mild disease or non-severe disease. So you're not sick enough to go to hospital with your COVID. So there's a medication called budesonide, and it comes in an inhaler like what you would use for asthma, or if you know someone with COPD. And that one can actually be prescribed by anyone that is a primary care provider, so say a family doctor or your nurse practitioner. And also it can be prescribed by any pharmacist out there in the community. So whatever community pharmacy you go to, the pharmacist there can also prescribe and offer you this inhaled budesonide. And what it's thought to do is really help people that have what we call respiratory symptoms of COVID-19. So things like, for example, cough that some people experience, it'll help make that go away sooner. So that's kind of the only exception to what was talked about there, but thought it may be helpful info to have.
And we're enriched in Lisas. Almost every committee I'm on has at least 3 Lisas for COVID. I don't know how this happened, but we have a multitude of Lisas. So we now Lisa B, Lisa N, Lisa C. Lisa N, would you have anything you wanted to add in there?
Sure. I wanted to add to Tasha's comment. I can't remember if you said, Tasha, that the budesonide inhalers are available from community pharmacies, so it's not necessarily designated prescribers. So the community pharmacists that you're most familiar with, and I think that was an excellent point that you made, Dr. Barrett, that these medications are available in your own community. So it's those are the folks that you're talking to and getting the prescriptions from. Are the folks that I work with, the pharmacists that do the assessment, are work from the hospital, and they do that because we know we can do really thorough. We have such great access to all the health information. As Dr. Barrett said, if you complete report and support, and then we know you're there and we can reach out and find that information and help you. So thank you for having us here.
Well, thank you all. And it was great to have Dr. Lisa, Dr. Tasha, and Lisa all giving us information. I think this is an area and maybe the questions that we'll take later on, not too long from now, will bring this forward. But we as the Health Association of African Canadians and as ABSW, we were concerned that our people were not aware of the therapies, the opportunities to have those. And certainly the messaging that would urge them to take advantage of those early was certainly not as robust as we felt it should be. So I'm glad that you've mentioned it, and we will, I think, want to reiterate that in different ways. So that people know that those are options for them. And lo and behold, not only that, but the inhaler that I think it was an inhaler. I'm not clinical, but I heard that you could use it if similar ways in which you might use it would be if you have asthma and that type of thing. So, that's really important to know. So thank you for that information. And tonight we have, we've heard about from Dr. David about how these variants keep happening, because we have questions about that. We're going to go there, and then of course what vaccines are available when you're eligible, because that's confusing. And now about therapy opportunities. And Sister Rose Fraser, who is a member of our COVID-19 initiative, is poised to tell us about some opportunities to go to clinics and get these vaccinations, and particularly one coming up. And I see that my co-manager Veronica Marsman is here with us. I'm so delighted. So there she is. So once you have told us about the opportunities for these clinics, perhaps I'll ask my co to kind of come in and start to facilitate the questions along with me. Okay, co, you good? Okay.
Sounds like a plan.
All right, terrific. So over to you, Sister Rose.
Hi, I'm Rose Fraser, and I am a retired healthcare provider, and I still feel like I'm working, but it's all good. So I'm going to talk just a little bit. This has been great. I've learned so much tonight, and also, you know, looking at all of the information that I've received, I thought, wow, I can share this with some of the people that I speak with tomorrow, even. But I just want to mention one thing. I need to preface this. The opportunity in the African Nova Scotian vaccine clinics for people to come, gather, feel at home, feel comfortable with people that they had already been familiar with. That really spoke volumes in as much as spreading the word about getting vaccinated. Because what happened was people who were at those clinics shared the information with their families, shared that the side effects weren't that bad. They shared the knowledge that they had gained, and they shared about the atmosphere that was the atmosphere was kind of created by those who are working in those clinics. And so I believe the importance of having community-based clinics really helped the spread of COVID-19 in our communities, because people came out to those clinics, and we would have loved to have seen more, even because we still know people that have not yet been vaccinated, even with the primary series. But it really helped to provide that place where people felt comfortable and they went to get their vaccine. So I'm going to tell you just about the next upcoming vaccine clinic, and that will be held on the number 7 highway, the Henry G. Ball Center. And these vaccines are for everybody who is eligible. It's at 35 Wilfred Jackson Way, Dartmouth, and it's to be held Monday, October the 10th, from 10:30 a.m. to 2:30 p.m. And it's offering the primary series and the Moderna bivalent to those who are eligible for it. And one of the things I learned when I was doing the vaccine clinics, so many people came in, they said, is the vaccine Pfizer? Is it Pfizer? And they wanted to know. But this information is invaluable. And the more that we can get this information out to our African Nova Scotian communities and the public, of course, everybody else, but primarily because I live in an African Nova Scotian community and I know the dynamics, the social determinants, the dynamics in the community. If we get the communities involved and engaged, we can help prevent the spread in our communities. So again, Henry G. Ball Center, 35 Wilfred Jackson Way in Dartmouth, Monday, October the 24th, from 10:30 a.m. to 2:30 p.m. And public health nurses will be there, and you will be able to get your vaccine and feel safe. And it's about staying safe as possible in these days ahead. And so I'm not going to take up a lot of time because there's been a lot of information given, and I have questions also. So I know that a lot of folks have questions that they want to ask. Thank you so much.
Thank you, Sister Rose. Really, really important that you are here to help us share this information. Very, very important. We know sometimes it's not what you say, it's how you say it and who says it. Over to you, Co. You're
I
muted.
gather at this time, we're opening it up for Q&As. So Rose, you already alluded to the fact that you have a question. And well, actually, you hold yours because I have one.
Okay.
And my apologies, folks, for joining late. Had a board meeting tonight. Paid work does, it does call. So I got to do my duties. So I caught the tail end when I believe, Dr. Barrett, you were talking about the puffers, or you, Tash, I'm not sure who now, but are they available, or are they available on the pharmacare? So if folks do want to use it, they're not going to be turned away or say it's going to cost an inordinate amount of money. Are they available under pharmacare?
Correct me if I'm wrong, either of the leases with me, but yes, they're available to anyone here in Nova Scotia. It is run technically through the Pharmacare program in the background, but accessible to everyone. And so it's available at no cost, which is really nice. And in addition to what we talked about before, I think it's really important just to emphasize that anyone, once again, can prescribe it. So, your family doctor, community pharmacist. And so if you know anyone that's struggling with their kind of breathing related symptoms with COVID, it can be a help.
Okay, thank you.
And the piece I'd add on to that is that sometimes people think only part of it's covered, and or because it's a higher dose than we usually use, say for asthma or something like that, this is all covered. They don't need to spare the puffer or anything like that. It's covered for the entire amount. So take the amount that you're prescribed. Don't try and wean it out, because I know people do that sometimes.
You're right, they do. All right, Ms. Rose, over to you.
So this question is for Dr. Sommers. You talked about the BA.5 variant, and I just wanted to know, is that, the vaccine, and is that only covering BA.5, or is that covering all of the variants, 1 to 5?
Great question. Thanks. So that particular bivalent has 2 strains. We'll have the original, we call it the ancestral strain that started way back in 2019, end of 2019, and it has the BA.5 variant of concern. For the past couple months now, BA.5 has been the predominant variant of concern in Canada. So locally in our own province and nationally, they'll take the PCR swabs and do additional analysis to see what type of variant it is. And we're seeing now majority of this, over 80, sometimes high as 90% of all the variants are BA.5. So that's the most predominant strain we're seeing out there right now. We do know that the ancestral strain, it does a very good job at what the vaccines are designed to do. That's to keep people out of hospital. The goal of having a more targeted vaccine is to provide that additional effectiveness. These vaccines are still new. They're just getting into arms eventually in the next, hopefully, few weeks, maybe even days. And over time, like we do with every new vaccine, we'll study and see what kind of effects they have. And hopefully, maybe end of this year, or most likely into the early part of 2023, we'll have an idea of what how effective they have been. So right now, all the studies have been shown just looking at that vaccine and how effective it is. We haven't had any comparison between Moderna bivalent versus Pfizer bivalent. So time will tell. We just need to time and get shots in arms and to see what kind of effect they have.
Okay, thank you.
Veronica, do you mind if I just add something there? Because
Sure.
maybe I wasn't as clear when I talked about the variants. The thing to recognize with the variants is that it's a change in a part of the virus. So the vaccines are targeted at the spike protein. When we talk about Omicron, Delta, whatever, BA.5, it's not that there's an entirely new spike protein. It's the same spike protein from the ancestral virus with some changes. So when you make a vaccine that targets a spike protein, it will still include the old parts of the spike protein. Does that make it any clearer? It's not an entirely new spike protein. It's just that there's some changes that make it different, but there's still parts of it that will respond to the immune system induced by the vaccine. Anyway.
Thank you. Great.
All right. More questions?
Well, Veronica, I have a couple of questions. I'm wondering if I could ask Dr. David to two things. And the first is, we know that, and we've talked about this in our work on this initiative, we know that many Black people who came to to come forward and get vaccinated, even though there was certainly, and there has been, and there should have been, mistrust of the health system given our history and our lived reality. They did that, and then after being vaccinated, hoped that they were done. They got their 2 shots, they got their 3 shots. They're like, okay, I did it. Now I'm all good to go. And then the variants happened. And they thought, and they asked us, well, what happened? You all said to do this, and then the variant happened. And so I wonder if you could just, in very lay people's terms, kind of walk us through how that happened. And then maybe also question number 2 is, if people didn't get vaccinated, and lots of people didn't get vaccinated, I understand in very simplistic terms that there would be more and more variants. So it's like the fewer people get vaccinated, the more variants there are. And again, I don't really understand how that happens. And I know I'm not the only one. So I wonder if you could kind of walk us through and also help us understand that, nobody, at least from our point of view, we never said we had all the answers, because we didn't. We were all kind of walking in the dark at the beginning, and we're still, now we're walking in the shadows trying to figure out how to get to the end. So can you tell us?
Okay, so let me take the second question first.
Okay.
So the key is that as this virus is copying itself over and over and over again, there are mistakes made, and that's where we get the variants from. So if you have a viral population that's really large, then the odds of getting variants is going to be that much larger as well. And the key is that if the virus is spreading unchecked, then you're going to get a larger number of variants than if the virus was checked in some way. And the way to check the virus is what Dr. Lisa said: get vaccinated, wear your mask, hand washing, all those kind of public health measures. But the key for us is that despite all of those measures, the virus will still mutate and we will still have variants. Just like we have influenza every year, despite, it's not, huge 90, 100% vaccination rate, but influenza changes all the time as well. And we have a virus here that is likely to do the same. So I think the bottom line is that we're going to have to live with variants and the need probably for repeat vaccinations every year. And this is what Dr. Ryan had sort of talked about. And again, he mentioned the fact that the original vaccines were made for the ancestral virus, and they were excellent. I mean, when we looked, we were astonished at how good these vaccines were in protecting against the ancestral virus. It was really astonishing. And, not only preventing severe disease, death, etc., but also in breaking that sort of transmission risk and all those kind of things, symptoms, so those are some of the things that we looked at. and was astonishing. But as we've gone along now, the virus has changed so much that it is escaping those kind of, if you will, other things that the vaccines used to do. The vaccines still protect, and I believe that what I said before is because we're not seeing a totally different virus. Influenza does that sometimes. You get a totally different virus. This virus is not doing that yet. And so the vaccines that we have, if you look at the original vaccine, still provides protection against the virus. And what we have now is that it's protection against severe disease, hospitalization, and death. But it's not stopping the transmission and the symptoms as the vaccines did before. And so this is why now they've modified the vaccines, and we will likely see that in the years to come, where we'll have modified vaccines being used, sort of for the yearly shots. I hope that makes it a little bit clearer. And Dr. Ann and Dr. Lisa, please jump in if you want to add to that. Does that help, Sharon? Is that kind of?
I think it does, and one of our board members, Chelsea, is writing in the chat that it really has helped. So,
Yeah.
Chelsea, if you want to add another question in, please do jump in. But I think it's been very helpful what you've had to say, Dr.
Yeah. So the bottom line for me is that we have variants. So the original promise, if you will, of the vaccines that we had then are not the same now, but they still do have some effect because we're not seeing a totally new virus. We're seeing changes which give it advantages for survival and evading the immune system, etc. But it's not totally different. So the vaccines will still have an effect on, inducing immunity.
I think the one bit, if I can just, and it's exactly
yes, Lisa,
what,
please.
that what you said, Dr. Haase, and what Dr. Ryan said as well, was there is value add to the vaccine between getting it plus getting the vaccine. There's actual value add. Most of us are going to run across this virus. Stop feeling bad about it. You do your best, but there is actually, even once you've had COVID, value add to both the durability and the breadth and the strength, if you will, of the immunity that you get after both. So it's not an either or. And to stay up to date, it's like exercise. You don't do it just once and get a health benefit from it. You kind of got to keep doing it, darn it. Vaccines are a similar thing.
So
Rhonda has a question
yes.
here that has come from the community. Is there a process that people have to report adverse symptoms after receiving the vaccine, including boosters? This would include brain fog, loss of memory, full body muscle soreness, etc., right after they receive the vaccine. Is there a process to report that?
I don't mind taking that one on. So thanks, Rhonda, for the question. There's common known side effects, and then there's side effects that are different than what we usually expect. So we know that after the vaccine, some people will complain of the usual redness at the site, sore arm, a little bit achy, bit of a fever. I'm actually living this right now. Well, technically my wife is, because I'm in Toronto at a meeting, but my poor wife is at home. She had her Moderna shot the other day. She's feeling a little achy. My 5-year-old had his second shot. He's feeling achy. They don't have COVID. They test themselves. So there's usual common side effects you have after getting a shot, and they usually get better after a couple of days, the last 1 or 2 days. If there is a serious reaction and things where someone has like an anaphylactic reaction where their lips are swelling, they get hives, their throat swells, those are very concerning ones that the public health wants to know about. So obviously, if someone has a concern like that, we suggest go get seen by a healthcare provider. it is a legal requirement in Nova Scotia that if someone sees an adverse event following an immunization, that they have to report to public health. If they're ones that cause hospitalization or severe disability or prolonged hospitalization, those have to be reported within 1 business day. And then anything else where it's just a very odd reaction we haven't seen before, then they have to be reported within a couple days. And so we have to do this as part of our national responsibility. Like we submit this information to the federal government, and they keep a track of all the vaccines and watch for vaccine safety, any sort of vaccine issues, because we're taking something that's and injecting to someone who's perfectly healthy. We want to make sure the vaccine is going to be safe and effective. We want to observe for any abnormal side effects. So to date, we've been doing this through COVID. We've had compared to other vaccines, we've had a very low number of adverse reactions following immunizations. But if someone's having issues after a vaccine, definitely get seen by a healthcare provider. There are some other symptoms like after infections, like the brain fog, the achiness, and that could potentially be symptoms of long COVID. That's something that public health doesn't really get involved with. We encourage people to get seen by their primary care practitioner, get checked out. There is actually a support system in place through primary care where they're actually helping manage individuals with long COVID symptoms. What I can do is I can get that information back to HAAC and ABSW to get that out to the group as well. But if someone has concerns, well, yeah, definitely please reach out to your primary care practitioner.
Chelsea's asking, just to clarify, if there are adverse effects, the health HCP, I should know
Healthcare
that. Provider, you report them to that person, correct?
Yeah. Sometimes people are very active and they will actually reach out to 811 on their own and report themselves. And in those situations, we will collect that information and a public health nurse will get involved. But preferably, like someone be seen by a clinician who knows the patient, who can assess the patient, put their eyes on the patient to see what could be going on. Because it obviously it could be a vaccine, it could be something else as well. So if it's a rash, we want to make sure, is this potentially connected to the vaccine or not. The other thing I should add too is in Nova Scotia that we have this whole protocol where we look at adverse reactions and determine if there's a known reaction or if it's something that's not known. And we actually have a relationship with specialists in infectious disease, cardiology, rheumatology, allergy medicine, that if we have a real concerning question and we can't figure it out, we will refer them to a specialist and they will see the patient and determine, was that adverse reaction due to the vaccine or is it something else? And they can also give us advice around future doses of vaccine.
I'm just going to jump in just to thank Dr. Lisa because I see she has to leave. So thank you so much, Dr. Lisa. It was really, really important information that you brought and it was easy to understand. We appreciate it. Thank you.
Thanks. And my apologies. I just got to zip off to the next.
Oh yeah, we understand. Life is happening to all of us. Thank you. Thank you again. Okay, over to you, Veronica.
Well, I see Lisa has her hand up. You've got a comment?
Thank you, Veronica. I just wanted to add to Dr. Ryan's great answer that there's also an added special protection for our children. There's a group of nurses at the IWK who do, if any child is admitted to the IWK emergency, goes through emergency department, and they've had a vaccine, and there's any thought that it's related, the reason that they've come to the hospital is related to the vaccine, they'd have special reporting for that to ensure, because we don't have as many studies around for our children receiving vaccines. So it's extra protection for our children who get their vaccines.
Okay, I'm just wondering, I see Sherry and you as well, Chelsea. So what are you guys hearing from community?
Truly, I'm not hearing a lot in terms of what they're saying about COVID. They're still very much those that wanted to be vaccinated did go and get their vaccinations, and those that were opposed still haven't been vaccinated. But my question is, I looked at what Dr. Sommers had there, and I think more than 6 months since I had my booster. Would it be advisable? You talk about older people. I consider myself one of them, even though I'm not 70 yet. But is it advisable that I get a second booster?
Plain answer, yes. And so for those from the after those official population over 50, we actually bring it down to 120 days or closer to 4 months. But yeah, you're definitely at a time now you can go ahead and book your second booster.
Yeah, I think I had mine in January, so.
Oh, you're due.
Yeah. Okay, yes, I'm due. And the other question is to Rose, who was talking about the upcoming clinic. Did I hear you say that, because I'm one of those people who want to keep it all one dose, one thing. Did you say it was only Moderna that they are offering?
No, there will be Moderna, bivalent, and also Pfizer.
Okay.
Pfizer, just the primary series, the one you had before, the one that was given before, that one will be given as well, you know.
Okay, but based upon that, if I get my shot,
yes,
then what Dr. Sommers was talking about, something coming down the line in about another week or two, would I still get that shot as well?
So I'm not sure about that. Maybe Dr. Sommers could answer.
No, that's what I want Dr. Sommers to respond to.
Yes.
So I suspect if we get our vaccine shipment on time, which I think they're expecting vaccine to be available in province sometime next week. Once we have it in province, I suspect that there'll be a little asterisk to that clinic saying that the Pfizer bivalent will be available. That's assuming that vaccine will be delivered. So we won't actually be able to officially say it. So we have vaccine on site and it's been recorded at the proper temperature and it's been accepted. So we're very careful not to start booking people until we actually have vaccines in hand. So we don't want to book all these people and have to cancel these clinics. So fingers crossed, the plane arrives, the vaccine's at the right temperature, and then we can hopefully update that. But I will connect with my colleagues who are involved in the logistics and say that, you know, if everything goes okay, the October 24th clinic, could they update it and say the Pfizer bivalent?
So Sherry, is that clear to you?
No, not quite.
So the key thing is that the bivalent is what's being recommended for boosting, right? For the booster. But right now, only the Moderna bivalent is available. But we're hoping and praying that the Pfizer bivalent will become available soon as well.
Okay.
All right.
I understand what you're saying.
Yeah. So if the Pfizer is available for that clinic at the Ball Center, then yes, it will be there. If it's not available, the Moderna will be there, which you can get. The Moderna is a good vaccine as well. So
I believe you.
Yeah,
It's
but
just
if you choose to get it, you can. But if not, then you wait till the Pfizer is available.
Okay, it's just that I'm thinking I'm over 50. It's been, I think I've got my booster in January.
Yeah.
So I'm looking to get that second booster. And if I can get it on the 24th, then I'm going to go for it.
Yeah,
I'll just wait to see what Pfizer brings down.
Good for you.
Sherry, just break some news to you. You're over 60, honey.
Oh, did you have to tell everybody? I was trying to be 55.
Okay, Sister Rose, I see your hand up there.
I'm over 65, by the way.
I know that, honey.
Yeah, she looks good. That's it.
Yes, the question that I've received from many community residents is about having COVID and when to get the vaccine after the
Right.
booster vaccine, after you've had COVID. How long, what duration between having COVID and getting the vaccine should there be?
Yeah, I can answer that one. So if
Yeah.
they're under 50 and they don't have a suppressed immune system, we would say 168 days or about 6 months after the onset of their symptoms. Basically, when you get infected, it's like having another boost to your immune system. It's like having another shot.
Yeah.
If you're over 50, it's 120 days. So again, it'd be nice to have it all simple wrapped up in the same number, but I think we chose to recommend 50 and above because of we know there's higher rates of chronic disease in African populations. We know because of the anti-Black racism. We know because of what's happened over the years that there's a larger burden of disease in that population. So basically, if it's 50 and above, it's 120 days. If it's under 50, it's 168 days or 6 months.
Okay, I think you already said that, but I was looking
That's
through my
okay.
notes. I got 3 pages of notes and I couldn't find it.
Yeah, no worries. You know what I'll do is I'll send out the slides afterwards that you circulated, and I'm taking notes on the questions, and I've been meeting with David and Sharon and Veronica, and then maybe we could work with the communication consultants in public health to take some of this stuff and create a product for you that you can
Great.
share with the community.
Yes, I know Chelsea has her hand up, Sister Veronica. I just wanted to make that point. I want to encourage you, Dr. Ryan, to put that down in a nice, easy to read, accessible thing you put on your fridge, okay? Because that would be helpful. All right.
I'm a big fan of one pager, so I'll think we'll get a one pager that we can easily send. That it's very straightforward. Yeah.
Tasha has also added the note there as well that pregnant individuals under 50 are also at the 120 days after being infected. So, all right, Miss Chelsea, honey. You have a comment or a question?
You're muted, hon.
Okay, we'll give her a minute.
Oh,
Her
okay.
computer will not unmute. Is there anything you could do about that, Carla? Are you able to unmute her?
You mean Kate tonight?
Yeah.
Oh, is it
Kate.
Kate tonight? Okay.
So Kate, you can do that, right? You know how to do that?
Yep. Oh, there we go.
Okay.
All right.
Thank you. Hi, Miss Veronica.
Hey, honey.
I just wanted to answer your question. So kind of similar to what Sherry said, a lot of community discussion just around not wanting the vaccine. There's a lot of community members that still don't have it. And then a lot of discussion around what Miss Sharon, asked about why people still have to be revaccinated, why they need boosters. So I was wondering if there is going to be a document coming out that is easy to read and simple that could explain that to community that they could also have on the fridge. Just so they can understand that it's changing and that's why the booster shots are needed. I feel like that's really important because a lot of people are just like, oh, it didn't work. There's no point in getting it. So I'm just wondering what's happening there.
Well, just like, if I can just jump in, just like what we heard in terms of the request and Dr. Ryan saying that, they'll get something nice and concise for us. And what we'll do is we'll get our own Dr. D to review it and make sure that it is plain language, easy for us to read, and that we can then get circulated. We might even have to talk in our meeting, Sharon and David, about another newsletter.
Yes. Yeah. And we did have, for what it's worth, we did have the messaging of stay informed, stay protected, stay safe. You can get, even though you've had your vaccine, you can get COVID. Yeah. And so the booster will help to protect you against severe disease. So we have had let me tell you, we've had lots of conversations about those messages. Okay. So Just want you to know we've been working hard, okay? But more is more. In this case, less is not more, more is more. So anyway, over to you, Veronica. I see Sherry has something.
Well, just before Sherry jumps in, Archie, who has joined us, has a question here too, that I know has already been addressed, but where's Dr. D? If you're over 50, when can you get the second vaccine? The booster, he means the second booster. We've talked about that this evening. So Dr. D, do you want to just give him a quick summary?
Why don't you take, Dr. Ryan, why don't you take that, please?
Okay.
Yeah, and actually, Tasha was very kind. She put something in the, she put it in the chat there. So yeah, so definitely, Archie, you're available to, you can get a second dose as long as it's been 120 days since your last vaccine, your last booster, or 120 days after your last infection.
But you might want to wait for the bivalent booster, right?
That could be within a couple weeks. I mean,
right.
Technically, we're recommending either or. I know there's a particular preference from the Black community, but again, fingers crossed that we'll have some information to share with the next week about the Pfizer bivalent, because I know it's a preferred product.
Yes.
Yes. So just so I can be clear, so it's 120 days after your last booster, or now I had COVID again, Labor Day weekend. So I have to wait 120 days after that to get the next booster? Okay.
Yeah. So basically we say from like when you had your symptoms or when you had your test. That's probably the easiest way to remember it. Yeah.
Okay. Thank you. And again, sorry I was late.
Always glad you're here, Brother Archie. Always.
Hey, Miss Sherry, you're back up, honey.
Okay, I was just wondering, you know, talking from a community perspective, what do you tell people when they say to you, I've had all the needles I'm gonna get and I'm done? Is there something you can address in your newsletter to talk about that? Because I've heard people say recently, well, I've had my, you know, series of it and I had a booster shot. I'm not getting any more needles. So tonight I realized after hearing what the presentations that this virus is forever changing. And I now realize that we have to protect ourselves with the various changes that are going on. And I would really love the idea of getting it one shot a year and having it clear. But I was just suggesting that maybe if you're going to do another newsletter, that something be in the newsletter to address that, because people are thinking, oh, I got my 2 needles and a booster, I'm safe.
Yeah, you're right, Chair. I've been hearing a lot of that as well. But yet some of these same folks line up year after year to get a flu shot.
Myself included.
Exactly. I'd love to be able to see these vaccines all into one, flu.
Yeah.
COVID. That would
just,
be great.
or even one a year. I'd be satisfied with that.
Yeah.
That
Any
will
chance of
come,
that, Dr.
Veronica.
Summer?
That will come.
Great.
I was
Great.
sitting here thinking the same thing, and that at some stage we're going to have a one shot covers all with, you know, anyway, that will come.
Beautiful.
That will come.
There's actually, this is still in research, there might even be like a nasal spray form of the vaccine. It's still very early on, but that would be another easy way to get a shot, because some people just don't like needles. But I think we're a bit ways out before we see that. There's some studies seeing if it's just as good as getting a needle. So, but yeah, these are all, like, I'm learning a lot from the questions people are having, and I think we could definitely support with your newsletter, and I think I see a whole other series of key messages coming out from this work. We just created some, but I've learned quickly that David Haase and all the infectious disease doctors are amazing editors. So if you need a book or edit it, David's your guy.
Yeah.
All right. I'll turn it back to you, Miss Sharon.
Well, Okay, well, I think we've had, you know, a really thorough airing of lots of things here, and it will be important going forward that we just, as my HAAC co, as opposed to my COVID co, because I got two co's on here, but as my HAAC co would always say, keep it real. The truth of the situation is that, you know, we did not have the answers in 2020 when we started. How could we? This was new to everybody. It was new to the whole world. We worked hard to try to stay in front of information. We brought information forward. We made it culturally specific, and we have to keep communicating. We have to keep communicating and keep encouraging our people, because, you know, we are at higher risk. And so, you know, that's the work of this initiative. And I just want to, you know, make it clear to brothers and sisters, as well as our allies in the health system, that, you know, we intend to stay on this. We're not going anywhere, but we are, you know, we are committed to doing our very utmost to keep people informed, keep them protected, and keep them safe. So having said that, now I want to ask Sister Kate to tell us about the fact that this has been worth your while, even though we wanted to have 500 people on this call. We didn't. However, all is not lost.
Has been recorded.
That's right.
So it will be available on our YouTube channel and Facebook. And if you have any questions, you can email.
Oh, we're losing you. We lost you. Come back.
You're gone on mute. Yeah.
Sorry. I don't know how that happened. If you have any questions, you can send an email to the email that I put in the chat right there.
Kate, when will it be available on the site?
Yeah, it will probably be a week. I have to wait until our glue Carla comes back, and then it will be available.
Okay. And we also want to let folks know that if there are questions from folks in the community, they can call the toll-free line, leave their question, leave their name and a number, and we will connect them with the appropriate doctor, whether it's Dr. Ryan, Dr. David, Dr. Lisa, whoever. We can connect them so that they can have their question addressed. The toll-free line is still active, folks. Please spread the word.
And it's for us, right?
Sure is.
Amen.
By us and for us and with us and all that. So any parting shots? I certainly want. No pun intended. Anybody want to have last word? Anybody?
I'll say, I'm going to see you on October 24th, Rose.
Yes,
Right on.
indeed.
Right on. That's great.
All right.
Okay.
Good to see you, Dr. Gaynor.
Yes.
And you see her comment in the chat? Did you see that?
Yeah.
Okay.
Feeling all
Thank
that
you,
love.
Yeah, we miss you.
Yes, we do.
I'm still here, just doing the work from a different angle.
Yeah.
Good to see you. It's good to see you.
And isn't it nice that we got it covered? So thank you to our presenters.
Did Archie have his hand? Was that you, Archie? Who had the hand up?
No,
I
I
was
was just clapping.
Okay, sorry.
Because we need encouragement. Thank you.
Yeah,
Thank
we
you.
do.
So I certainly want to also, again, thank Dr. our always present and so committed Dr. David, Dr. Ryan. We're seeing you every week these days. So we're family now. We're going to be connected at the hip forever now.
Yeah.
And Dr. Lisa did a terrific job. And Dr. Tasha and Lisa, we appreciate you. Okay. You got some of our HAAC and ABSW love tonight. So thank you all. And as we say, stay informed, be protected, stay safe, be well. Love y'all.
Thank you.
Talk
Thank
soon.
you. Thank you.
Okay.
Bye-bye.
Good night.
Bye now.
Bye.